Hello, everyone. Thanks for joining us at this conversation to discuss medication-based treatment in jails and prisons. I'm Regina LaBelle. I'm the director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown Law. I'm really pleased to be joined here today by some great panelists, and we're going to talk about model state legislation that we've been working on for quite some time with the Legislative Analysis and Public Policy Association, and Kemper is going to be reviewing that legislation with Shelly Weizman. I'm going to introduce everyone in a moment, and then I'm going to take a few minutes to review the issue and why we've chosen to focus so much on medication-based treatment in correctional settings. Then again, Shelly and Chan will review the legislation. And we'll have a panel discussion where we'll be joined by TK Rabii, who I will introduce in a moment. And then we'll take questions. So if anyone has questions, please put them in the Q&A box. The chat box is not functioning, but the Q&A box is. And we will then go over those questions towards the end of our time. So first I want to begin by introducing all of the panelists, and sorry. So I want to take a moment to introduce the panelists. First, we have Shelly Weizman. Shelly is our Associate Director at the Addiction and Public Policy Initiative. Shelly joined us after serving in Governor Cuomo's administration as the Assistant Secretary for Mental Hygiene. She also served as the Policy Director for Managed Care at the New York State Office of Mental Health. And she served as a Senior Staff Attorney at MFY Legal Services, a not-for-profit organization in New York City. She received her JD with a concentration in health law from Seton Hall and her undergraduate degree from the University of Houston. Next, we have TK Rabii, who is a recovery advocate and activist working to assist people achieving their recovery goals, whatever that may be for them. TK currently works as a clinician at Ellis Pros, which is a comprehensive recovery-oriented program for people with mental illness in Schenectady, New York. TK facilitates and co-facilitates a number of different groups, including the peer empowerment group of the Capital Region. He's currently in the process of receiving his certification in chemical dependency counseling from the state of New York, and is also a person in recovery, which for him means it's been 5 years without using alcohol and other drugs, as well as maintaining his recovery for mental health. And then we will hear from Chan Kemper. Chan is an attorney with LAPPA, the Legislative Analysis and Public Policy Association. Chan is a member of the Kentucky Bar and served in the Kentucky General Assembly, where she drafted numerous pieces of legislation, including several that concerned substance use and opioid use disorders. She clerked for the presiding judge of the Superior Court of the Virgin Islands and received her law degree from University of Cincinnati and her undergraduate degree from Fisk University. So I'm going to go over a few facts about medication-based treatment in correctional settings, a bit about litigation that we've seen, and then we've taken a deep dive into some state legislative actions that have occurred in the last couple of years, and we compared that to the legislation you'll hear about. So first, we know that there are about 3,000 jails in the United States. This is data, most of which is from the Bureau of Justice Statistics. And these jails house about 745,000 people. Now, nearly 2/3 of people who are incarcerated in the United States meet the diagnostic criteria for a substance use disorder, and many of whom have an opioid use disorder. But we also know, and this is from the National Academy, that about 5% of people in jails and prisons receive medications for opioid use disorder. Now, this percentage is a couple years old, so it might be higher now, but it's nowhere near what it needs to be to meet the needs of this population. And why is it so important? that we focus on the population of individuals who are incarcerated with opioid use disorder? Well, for one, we know that they have much higher rates of overdose death upon leaving incarceration. And this is well researched. And we know that, for example, one such study from Washington State showed that upon leaving incarceration, individuals had a 129 times greater risk of drug overdose in the first 2 weeks of leaving incarceration relative to the general population. So we know also from states such as Rhode Island that introduced such medications for opioid use disorder in their correctional settings. They not only reduced overdose deaths among the incarcerated, among newly released individuals, but also among the general population. And a very significant finding is that the majority of people who begin treatment behind the walls, treatment for medications, treatment using medications for opioid use disorder while they're incarcerated, continue that treatment. So in the last several years, last about 5 years, we've seen quite a number of lawsuits that have been brought. Usually the cases have been brought on behalf of an individual who is entering a jail or a prison, who's currently on a medication, any one of the FDA approved medications. So we know that there are several cases. There have been in Maine, Massachusetts, the one in Whatcom County, which is the second one here, Whatcom County, Washington. That was a class action lawsuit, and that settled. And since then, Whatcom County has introduced a medication-based treatment program in their correctional settings. So litigation, certainly as lawyers, we understand how important litigation can be to bringing attention to an issue. But again, many of these cases were individual cases, and they may not have had the broad-based policy efforts or broad-based policy impact that legislation can have. So we also took a look, we had have a great extern from Northeastern Law who took a look at legislation that's passed that has passed state legislatures in the past couple of years. And we compared the legislation that you're going to hear about momentarily with the legislation that passed. So a couple things stood out for us. Number one, we found that 4 of the states that had passed legislation mandated that all forms of FDA approved medications for opioid use disorder be offered to an individual. 4 also required that anyone with an opioid use disorder should be eligible for receiving a medication for opioid use disorder treatment program, as opposed to just singling it out for perhaps women who are pregnant. 1 specifically included withdrawal management protocols, 4 required counseling, and 6 required specific reentry planning programs to be put in place. None said that you cannot charge a fee for medication for opioid use disorder treatment. And none of the states had allowed for an exemption for a county to implement the program. None specifically did that. A few of the states may have passed legislation, but they didn't include funding, which obviously makes it harder to implement such a program. And a couple were pilot programs, so they had a specific data collection program that they suggest, which in the model legislation, data collection is another piece of the legislation. Several states introduced legislation, those are the purple states, but they subsequently, that legislation failed to pass in these past legislative sessions. And in one state, the state of Ohio, the governor vetoed the measure, which would have established a program to reimburse counties for providing MOUD in jails. So what we have, I'm going to now turn it over to Shelly and Chan, who will discuss the model legislation. And we can come back again and we'll have a panel discussion. And again, if you have any questions, please put them in your Q&A box. Thanks.
Great. Thanks so much, Regina. And just before we get into the walkthrough, a couple of points that we wanted to make. So, and just personally for me, so pleased to be part of drafting this model law. I really approached this work from my perspective as an attorney and as a former state official who's had to develop and implement programs like this, as well as a person in long-term recovery myself. And, I think, many people would agree that we're really in a pivotal time right now where we really need to take a look at how do we use the law to advance public health measures. And right now in a pandemic, we can't forget that we still are and continue to be in an overdose epidemic that has been exacerbated by the conditions of the COVID pandemic, social isolation, stressors, and other kind of challenges that people are facing right now. And we really feel that this issue, access to medication in jails and prisons for opioid use disorder, is a specific, targeted, actionable measure that states can take right now to make a dent in overdose deaths. And we've seen that this works. In Rhode Island, for example, they saw a 61% reduction in overdose deaths for people who were incarcerated after implementing all three forms of medications for opioid use disorder in their correctional system. And that reflected a 12% overall reduction statewide in opioid overdose deaths. So we know that this type of targeted measure has a very large and significant impact on reduction of deaths statewide. And we're starting to see this in counties across the country, as well as some states. So, what we're going to present right now is really a framework. State policymakers can pick it up and take it word for word, or adjust to meet the individual needs of each state. States have different systems, different decision-making entities. And so, something like this, a model law for all 50 states, can be a really good framework and can be added to as well. I mean, this really focused on medications, but robust treatment programming, mental health programming, access to health insurance. These are all things that we talked about including in here, but decided, we really need to take a targeted approach here. And, we all know, I think, that there's a lot of work to do, a lot that has been done, but a lot left to do. And, providing people with the services and supports that they need to avoid jail and prison entirely, to divert people from the criminal justice system entirely, and to address the disparities that we know are out there that cause people, particularly people of color, to go into the criminal justice system and not get access to care in the first place. So we really look at this as a fundamental measure that is a necessary building block to stem the tide of overdose deaths that states can do right now. So with that, I'll turn it over to Chan to start the walkthrough. And we're very pleased to be sharing this with you all.
Thank you so much, Shelly. As Regina mentioned, my name is Shan Kemper. I'm a senior legislative attorney with LAPPA, which is the Legislative Analysis and Public Policy Association. We are here today to talk about our joint collaboration, the Model Medication for Addiction Treatment in Correctional Settings Act. I'm going to call it the MAT Act because that's a mouthful. Before we get to the meat of the discussion, I want to talk a little bit about what LAPPA is. We are a nonpartisan 501c3 nonprofit organization. We are funded through the Office of National Drug Control Policy. We're based in Washington, D.C., led of and comprised of experienced attorneys. And our main mission is to draft model legislation, conduct legal and legislative research and analysis on effective law and policies, primarily in the areas of public health and safety, substance use disorders, and the criminal justice system. So as Shelly mentioned, essentially what the MAT Act is, it's a model law that provides policymakers with a comprehensive and evidence-based framework for ensuring that incarcerated persons with a substance use disorder be provided access to FDA-approved MAT in state and local correctional settings. If you want to follow along, or if you want to look at a copy of the MAT Act as we talk, you can find it at this link here on our legislativeanalysis.org website. And I believe there's a link in the webinar RSVP. So a little bit of history on the MAT Act. The MAT Act was written in collaboration with the O'Neill Institute for National and Global Health Law. And I believe this is probably the 13th or 14th draft, which we've had reviewed by experts and policymakers in the field of criminal justice, law enforcement, and medication for addiction treatment. And I want to go over some terminology before we start. As most of the people on this webinar know, best practices and languages surrounding and concerning treatment of substance use disorders are fluid and ever evolving. Some people use medication-assisted treatment. I believe Regina and Shelly use medication for opioid use disorder. There's medication-based treatment. We, LAPPA, decided to use medication for addiction treatment primarily because ONBCP requested that that term be used, but for the most part, they are interchangeable. Further, we use the phrase correctional setting to encompass any state or local jail where someone is incarcerated before, during, or after trial. Also, the MAT Act uses the term substance use disorder as opposed to opioid use disorder. This is very deliberate. Currently, in correctional settings, primarily people are treated for opioid use disorder, but this may change, which is why legislative provisions specifically in the MAT Act use the term substance use disorder. We want to make sure that we have an intentional fluidity to the MAT Act so that it can be expansive without extensive revision or amendment down the road. So why do we need the MAT Act? I don't want to belabor the point. I think Regina did a really good job of explaining what's going on in our country. But more than half, 58% of state prisoners, and 2/3, 63% of sentenced jail inmates meet the criteria for a substance use disorder, which is why we need the MAT Act. A formerly incarcerated person's risk of death within the first 2 weeks of release is more than 12 times that of other individuals, with the leading cause of death being a fatal overdose. And we know that medication for addiction treatment works. According to the American Society of Addiction Medicine, evidence shows that methadone, buprenorphine, and naltrexone all reduce opioid use and opioid use disorder related symptoms. Further, we are in a unique position, considering that the criminal justice system is the largest source of organizational referrals to addiction treatment. We are in a unique position to provide a valuable opportunity to facilitate the path to recovery. So there are 5 major components of the MAT. We have program requirements, training and staff engagement, reentry and treatment, reporting, and funding. And I'm going to go through each section in turn and sort of just hit our program highlights, or highlights for each section. And Shelly's going to chime in and just help kind of elucidate some of the points. The establishment of the MAT program is to be administered throughout correctional settings within the state. This does not require the same standards as an OTP. So the MAT Act doesn't require that states meet the standards of an opioid treatment program. And this is deliberate. Opioid treatment programs are much needed, but they are federally accredited and certified by SAMHSA, and they are very, very detailed. This allows for correctional settings to sort of on the ground begin their MAT Act program, either through meeting the requirements of the Act themselves or entering into agreements with other facilities or the community to meet the MAT requirements. There's also an emphasis on requiring participant consent. People in correctional settings have a right to make medical decisions. The Act states that it is 100% the participant's decision to take part in a MAT program. And decisions related to actually taking a medication are made by both the participant and, of course, a qualified provider. Shelly, did you want to say anything about the consent issue?
Yeah, and actually going back to the previous slide, I think what we're seeing is that to get this done, it really can require an all hands on deck approach that might either involve the jails or prison in the state themselves being certified to be an opioid treatment program and dispense methadone and prescribe buprenorphine, et cetera. But we're also seeing that there's a lot of innovation around partnerships with local opioid treatment programs and local treatment providers in that community to do things like guest dosing or actually enrolling people in the OTP and, having a satellite clinic at the jail. We've seen some mobile methadone and going to the delivery to the jail. And right now there are some pending regulations, hopefully to expand the availability of that at the federal level. Certainly there are a lot of different models, and in this model law, we left it open to the individual states.
So you have two, right? So as Shelly mentioned, we've set it up so it's almost like a Chinese buffet. You have many different options in terms of whether or not, if your state is jails are largely autonomous from the Department of Corrections, or if they're run by the Department of Corrections, we've language included to help you implement the program regardless. And then one of the program highlights is we require an immediate assessment of an individual for a substance use disorder, because the sooner you have someone in the program, the sooner they can get treatment. We also require access to all forms of medication addiction treatment for program participants for the duration of treatment. And we include provisions for protocols for withdrawal management, of course.
Yeah, and to just chime in on that, we don't go into detail in this model law on withdrawal management for other substances, stimulants, benzodiazepine, cocaine, et cetera. But certainly we're seeing that there is an increase in polysubstance use in some parts of the country. Opioid use isn't the main issue anymore. It's methamphetamine. So different trends around the country. And what we see in our research is that a withdrawal protocol that's in place that calls for immediate assessment, screening, and connection to medical care for folks is essential to prevent adverse events. And these adverse events, up to and including death, occur quite often in the first day of somebody's incarceration. So somebody is just, intake into jail, and within 24 hours can have a very serious and sometimes life-threatening adverse event. And so that withdrawal protocol is critical.
Another program requirement highlight is no person is denied participation or dismissed from the MAP program on the basis of a positive drug screen or administrative segregation, which is solitary confinement, or a disciplinary infraction. And that's also important. If we are acknowledging that addiction is a disease, we don't want to treat it like something that's not a medical issue. Requirements, and also program requirement highlights also include that we require that correctional settings implement program policies and procedures that cover appeals and challenges by program participants, the use of telemedicine, which is crucial because we acknowledge that many of the local correctional settings and even some of the state correctional settings may not have immediate access to the MAT Act program requirements on the ground. And of course, agreements with community-based providers to facilitate reentry and access to treatment post-release. Next, we get to the second prong of the MAT Act, which is training and education highlights. So prior to implementation of a MAT program, and on an ongoing basis, correctional setting staff must receive regular training on topics related to MAT treatment in correctional settings. And this includes a plethora of issues. That includes explaining them about screening, assessment, and treatment protocols, getting input from them and discussing about the use of FDA-approved medications to reverse an opioid overdose, what medicines are actually going to be used, how the prison or correctional setting will be handling diversion. We've heard from numerous experts in the field that said buy-in from your staff is crucial to the success of a MAT program. So this is why that's a really important part of the MAT Act itself. Shelly, did you want to say anything about that?
Yeah, I mean, just to really double down on what Chan just said is that this implementation of a program like this often requires a culture shift in the jail. In many jails, buprenorphine is a highly diverted, it's viewed as contraband. And there's a lot of resistance to, why would we provide people with something that is diverted, is contraband? We see this as a problem. And what we've seen in jails across the country that are doing this is as soon as they start providing access that is in a medical framework to people with opioid use disorder and access to buprenorphine specifically, the diversion goes down, the contraband goes down, people are getting the actual medication that they need to treat an illness. And so, really having a intentional initial and ongoing training, education that meets people where they are on this issue is critical.
Thank you. We next have the third prong, which is reentry and treatment highlights. So every person admitted to the MAC Act program must have a reentry plan made for them and implemented for them. This plan must include access to any documentation necessary to continuity of care when they leave, any necessary medication as allowed by state or federal law, scheduled initial appointments with a community-based opioid treatment program, qualified provider, or healthcare practitioner. And we also require that the person is provided naloxone, and also given education on how to use it. And this is a crucial aspect of it too, because we recognize that having naloxone helps. There's studies that show that, and it was something that a lot of our experts told us that recommended that we include. Next, under the reentry and treatment highlights, the MAT Act requires that reentry include collaboration between the participant's healthcare provider and parole or probation staff. And it forbids a participant from being subject to a parole or probation violation solely because of the use of MAT. Just to piggyback on my point a little bit earlier, we are treating this like what it is, which is a disease. Then we don't want to punish people for trying to get help. The MAT Act also provides that any additional guidelines or standards not contained within the Act be based on the most current recommendations set out by the National Center for Correctional Healthcare on MAT. And that's just because this is a detailed subject. As Shelly mentioned, as Regina mentioned, and as I said, this is a framework. We believe it's a really good legislative framework, but the details of how this is actually run belong likely in regulation. And we find that the National Center for Correctional Healthcare has done a great job of helping to provide that. There's the next prong is reporting requirements. So the MAT Act requires that state and local correctional settings track, monitor, and evaluate the efficacy and success of a MAT Act program. And we also require that an annual report be sent to the governor and state legislative committees. And this includes several things that we would like to be studied, such as the number of participants, factors such as the rate of opioid overdose mortality upon reentry, before and after correctional medication for addiction treatment, program implementation statistics such as behavior infraction rates, recidivism rates, HIV and hepatitis C treatment rates, among a variety of factors, program retention. Shelly, did you want to chime in on this one?
Yeah, sure. So, the themes here in this model law are about transparency and accountability. And there are some data collection pieces in there. And again, each state might approach that differently. But what we've seen is pilot programs and implemented programs doing really robust data collection and reporting. And we see things like, following implementation of these types of programs, we have sustained employment increases, significant increases, reduced recidivism, housing stability. So true outcome measures are being collected here. And, just the basics. Some jails are, this is really going to be new and they're not necessarily set up to have kind of a really large data collection and evaluation operation. But this gets folks started so we can really track what's working and know what's working, what's not working, and move ahead into best and promising practices.
Right. So why should we pay for this? That's a question that many people are probably going to ask. They know that medication for addiction treatment might work, but it's expensive. Well, there are a few reasons. First, people recover and can live and thrive, and that's a pretty big deal. That's important. Second, the estimated cost of the opioid epidemic was $504 billion in 2015. It's 2020, and I'm sure that number has gone up significantly. And finally, research, particularly on methadone, indicates that in the long term, medication for addiction treatment programs in correctional settings are cost effective. Comprehensive drug treatment programs in jails are associated with reduced system costs. So the data indicates that medications for addiction treatment are cost effective and cost beneficial. It also helps break the cycle of recidivism that results from the underlying disorder. So getting treatment while in a correctional setting can help stem the cycle of arrest, incarceration, release, arrest, incarceration, and release associated with substance use disorder. Shelly?
And we're seeing that in Albany County, New York, for example, after the sheriff there, Sheriff Apple, implemented all 3 forms of medication in the jail in Albany County. They saw a huge reduction in the people that were coming to the jail because it was the same people cycling in and out. And this stopped that cycle. And he decommissioned 100 jail cells because there was just no need for all of this jail space. So what we're seeing across the country in jails where this is happening is people get connected to treatment, and they don't come back to jail.
And the next question is, how do we pay for this? Well, the MAT Act is written with the understanding that each state will fund their MAT program differently. The Act also provides that states must pursue federal funding, matching funds, and foundation funding. Also, another potential funding source for medication for addiction treatment programs are opioid settlement funds. Shelly, did you want to jump in on the funding?
Yeah, I mean, we're seeing different funding organized differently. There are some states that have really, appropriated significant dollars to get these programs up and running, and have really kind of demonstrated a serious commitment to it. There are some counties that have sought federal grants to, start launching pilots, and so we, really started seeing the results of this. But essentially, as we outline in the model law, it can't be an unfunded mandate.
Right.
This is something that's, it's not hugely expensive, but there is a cost to getting these programs up and running.
Thank you. So in summary, statistics indicate that MAT, medication addiction treatment, is desperately needed in our correctional settings. And we know that MAT works. We know that it works. And the MAT Act is a model law that provides state policymakers with a comprehensive and evidence-based framework for ensuring that people who need treatment get it while in correctional settings. And it's an act that has been reviewed by experts and policymakers in the field. And at a minimum, we know that there are societal and financial benefits to providing MAT treatment in correctional settings. And we hope that the MAT Act helps provide a legislative framework for doing so. If you have any questions about the MAT Act or you want to see a copy of it, you can find it on LAPPA's website at legislativeanalysis.org. And I would be absolutely happy to answer any questions about the Act. My email is ckemper@thelappa.org. And I believe that the O'Neill Institute will also be sending out a copy of this presentation after the webinar. And I just want to thank Regina and Shelly for having me here today to discuss the MAT Act. It's very exciting to finally get it out there.
Awesome. Thank you so much, Chan.
Thank you.
So I think right now we're going to kind of pivot to a conversation with all of our, all the folks here. And there's a lot of great questions coming in on the Q&A, and we'll try to get to all of them. But first, I wanted to give TK a chance to talk a little bit about, what from your kind of personal experience, your professional experience, something like this could mean and could look like on the ground, and why is it so needed, and what would be kind of the key elements from your perspective?
So thank you, Miss Shelly. So as Shelly had mentioned, right, I've been in the prison system, right, both as an inmate in the jails and also working on the other hand as a treatment provider dealing with individuals who become incarcerated. And I've seen and witnessed personally and professionally the difficulties that individuals face with getting their MAT in the criminal justice system. For myself, right, going through jail, that was it took me probably about 5 days to even start to begin the process of getting MAT. And I had to beg and plead while I was going through withdrawals. And I felt like, right, when you're going through those withdrawals, you feel like you're dying, right? And you can't focus on, right, those things that they encourage in incarceration, which is rehabilitation. You can't rehabilitate because you're sick, right? And you're focusing on, right, how do I feel better? And it wasn't until I was finally able to get the MAT that I finally was able to kind of find that balance in during my time while I was incarcerated. And when we talk about MAT and the benefits of it, right? When we think about mental health medications, right? We can't treat people or work on the rehabilitation piece with individuals if we're not providing them the basic medications that they need. If someone has certain psychiatric diagnoses, we wouldn't deny them Seroquel, we wouldn't deny them their lithium. If someone had medical conditions, we wouldn't deny someone insulin, right? So treating MAT like those medications and like those medical conditions is important because those are the things that save people's lives. And for myself personally, and I think you hinted at this, Shelly, right? One of the biggest barriers that I had with getting MAT was, right, there's the stigma of what it looks like for an individual who suffers from opioid use disorder. And one of the things that I heard constantly from inmates and being, correction officers is that, right, heroin is a white person's drug. You can't use heroin, you're Black. And that stigma, right, and that societal pressure and bias, right, contributed to me having to suffer for 5 days without getting MAT. So I think that this conversation is really important because it allows us to create these structures and these frameworks to work on providing people with adequate care and giving them, right, what's within their rights to receive as human beings and treating them with respect.
Yes, thank you, TK. And you talked about, stigma. And, I wanted to kind of have a little conversation about that, having a literally legislation and a law that requires this. How do you think, TK, and then, maybe open it up to Regina and Shan, that this could, why would something like this be necessary to kind of get around the stigma of medication or the stigmas or biases like what you mentioned, TK, individual people making individual determinations just based on what they think?
So I think it kind of helps one to kind of start that conversation, right? Because the criminal justice system, right, has this very authoritative power in our country. And I think that when individuals see that, wow, they're actually taking this seriously and they're looking into and working on changing some of the, structures of the system, it starts to make a big difference because I think a lot of the stigma that comes from it is, right, when people enter the criminal justice system and they're not receiving MAT, right, they come out, they engage in recidivism, right? So if we're addressing it right there in the criminal justice system, it reduces those rates of recidivism and allows people to leave the jails and the prisons and come back out into society and show people that, look, right, people with substance use disorders don't just go back to jail, right, time and time and time again. They can get healthy, they can recover, and they can get help.
Awesome. And kind of along those lines, we had a question here, and maybe Regina, you can take this one. It was about, what are kind of some of the chief obstacles for maybe making this happen, whether it's from, the criminal justice and judges, wardens, sheriffs, is it the money? Is it the stigma? And I'll add a question to that is, how can the folks that are listening in address these issues in their own communities?
So this summer we had Dr. Ruth Potey, who is the chief medical officer for jail in Franklin, Massachusetts. And she has a really great graphic of the barriers that exist to setting up. Their jail became an opioid treatment program that can provide methadone. And so it's like when I used to practice law, and the senior partner said, lawsuits are not difficult. You just have to get from step A to step B. But all during that time, they put barriers up. And that's how, when you think about, all we need to do is provide medication to people with, the disease of opioid use disorder in jails and prisons. How hard can that be? But it's all of the above. There's the psychological problem of getting a new program introduced. When you think, we've been doing it this way for a very long time. And this is, we know how to control our environment at this time without this. So you introduce a new program in, and there's all sorts of factors you need to take into account. One is the stigma, and that's why we talk about providing education about medication, what it means, having people like TK, engaged in the process to talk about what this would have meant to him. So the stigma certainly is a big barrier. The second certainly is kind of, it's pretty new, and we do have some research. Rhode Island had their program, and Rikers has had a program for decades. But is it really going to work in my state? Because my state's not the same. Rhode Island's, a unified system, may not work. And there are monetary issues. Both Shelly, myself, Chan, we all worked at the local level of government and understand that money is in tight supply. It might be distributed wrong, but money for new programs is tough to come by. That's why the federal government funding has been so important for some of these pilots. But the problem with the federal government funding is that what the government gives, the government can take away. So if you have a pilot for a couple of years, someone's going to have to pay for that. So that's why the data collection is so important, to show we've saved X number of dollars. And we have decreased recidivism, and fewer people are presenting. So it is all of the above. It isn't only financial resources. It's also, the other thing we cannot underestimate is workforce shortages in many parts of the country. There are treatment deserts all over the country. So if we say you need to provide medication-based treatment, okay, I need a data wave doc if I'm going to provide BUP. I might need an OTP. Is there an OTP nearby? We need those methadone van rules to change. That might change it. Yes, it's all of the above.
Great, thank you. And I think that answered a few of these questions. Let's see. Whew. So we did get a question, and maybe Chan can take this, about mandating certain type of therapy or cognitive therapy as part of this program. And a question on, actually, we'll stop there. So, that the elements of this model law, obviously the focus was on the medications, and we mentioned therapy, but what's kind of the balance there? And Chan, when folks are kind of taking a look at this in their own states, what are some options or ideas that you all heard as you were getting feedback from experts on this?
So when we were researching and drafting this, initially, one of the drafts, we did mandate cognitive therapy as part of medication for addiction treatment. And what we heard from numerous experts was that was not maybe the best way to get people started and continue on their journey in recovery. And the rationale behind that was that some people may be resistant to that. Some people may not need that. And if we are treating this like a medical disorder, we want to get them the medical treatment. And then if they feel they need, or in talks with their healthcare practitioner, feel they need additional therapies to help with that, that is something that we've planned for in the legislation. So part of the reentry and treatment program section is that upon their reentry, like doing their reentry plan, we give them resources to reach out to cognitive therapy persons or to get therapy or peer support. That's another prong that's in the bill, is that there are peer support. They can reach out to peer support specialists that the correctional setting will set them up with. But we don't mandate cognitive therapy or behavioral therapy as a part of medication for addiction treatment, because first and foremost, the main point of the medication addiction treatment section of the bill is to save lives. And we know that medication can help with that. Cognitive and behavioral therapy, we believe in it. We understand that it works, but it is not the main focus of getting people into treatment as part of the act. Does that answer the question?
Yeah, definitely. And maybe TK, if you could talk a little bit more, what's the balance between medication, therapy, recovery, support, peer support? I mean, there's a lot out there, and there's different kind of philosophies, right, about medication first, or no, it has to be paired with therapy or with counseling. And there's been different studies. And so from your experience and perspective, what should really be the focus here as folks kind of sit down to really do this in their own state or community?
So just from my personal experience, I think definitely medication first, right? Because individuals aren't able to engage in therapy if psychologically and chemically they're not in a state of balance, right? They're not going to be able to take in as much as the information or fully engage like we would hope, right? If we're not addressing, right, that chemical and psychological component. And with medications, right, especially with MAT, for a lot of individuals, right, there's a lot of other stressors that come along, especially with being in jail, right, in prison, a lot of psychological stressors that occur. So, right, to be able to get rid of this one big stressor, which is dealing with the craving for opioids, right, like that's a big, thing to address, like right then and there. And then if individuals are willing and open to engage in therapy, I think it can do a lot of good. Because as I've learned throughout my career, right, in this field, is a lot of substance use disorders, right, I try to look at them as symptoms of something deeper, right? So a lot of times when we're talking about substance use disorders, right, they're the results of things like trauma, right? They're the results of, right, cultural practices that people have witnessed and engaged in. So I think that the therapy is definitely beneficial because, right, like it allows us to go deeper and kind of address why are we using the substances and kind of create that timeline to get people to work on changing those behavioral and thought patterns that they engage in. But right, we want to meet people where they're at. So if they're not with it, right, we got to try to kind of, right, work with them as best as they can, but definitely instilling the medication first is paramount above everything.
Thanks, TK. A couple of kind of technical questions, and maybe Regina, you can take these. We got a question about, the logistics of methadone in jails and prisons. So one question we got is, since jails and prisons are not OTP providers, how do jails get around the induction of methadone? We hear feedback, from the DEA, different things. And then kind of along those lines, we had a question about training programs for correctional staff, or best practices and suggestions for cultivating that really necessary culture change.
Great. So a couple things I'd recommend. One is the Vital Strategies and National Council did put together a workbook toolkit for jails on how to implement a medication-based treatment program in your jail. And I think that's a great resource. We'll make sure that when we send this out, we'll include that. I don't recall if it's on our website. I don't think it is. It is.
It is. Mhm.
Okay, so in the chat is a link to our website, and you can link on that because it talks a lot about that. The other piece about methadone clinics and opioid treatment programs. So a jail can become a certified licensed OTP, which is again what they did in Franklin, Massachusetts. Dr. Poti is an expert in this. She has her own website, that I'm sure they could provide additional information, as well as American Association of ATOD. They could also provide information about what are all the steps. But I want to emphasize one of the programs, the webinars we did early on in the pandemic was about the revisions that have been made to buprenorphine, methadone treatment regs, the treatment regime in this country, and the multiple layers. And we have been, outspoken in our position that those regulations should be changed and extend. So where possible, post-pandemic, they need to be revised, because what we have heard is that they are helping people retain people in treatment. And we really need to think about, are these barriers that are put up, are they just barriers for barriers' sake, or should they be removed over a long period of time? So we have another in our series of webinars, we discussed that as well with a board member for the American Society of Addiction Medicine. So I'd refer you back in the chat to many of our previous webinars.
And I'd like to say something about training and buy-in from staff and getting your staff on board. Well, I think it's two-pronged. I think one, it's just really crucial that you treat your correctional staff like what they are, which are intelligent people who want to do their job in a safe and healthy manner and want to help the people that they are, by and large, want to help the people that they are overseeing, are working with. And that means discussing with them the changes that are going to come as part of the MAP program and reaching into discussing their fears. I mean, over and over, we were told that the programs that worked the best, the programs that had the most success, were programs where the staff felt that they could talk to supervisors and talk to people about their concerns about MAP in the prisons, in correctional settings, and also where there was continued buy-in as time went on. So trainings, discussions about it. Also, the National Sheriff's Association has policy paper, I think it's called Jail-Based Medication-Assisted Treatment, and it does a really good job of laying out why someone in specifically a local correctional setting or a jail would want to invest in medication addiction treatment. That can kind of be, I think, a good way of starting to look at how do we discuss this with staff? How do we get staff buy-in here?
Excellent, right. A lot of work's been done on this issue and a lot of great resources out there for states looking to draft legislation and for local counties and state prison systems that are looking to implement. We got a couple questions in around the efficacy and approach around the different types of medications that, some of the comments are that methadone's been historically, there's been resistance to it, that there seems to be more openness towards other medications. And we did write in here in the model law that all three forms of medication would be required, with the exception that if there is literally no prescriber or clinic even, available, that would be at the discretion of the state to provide that exception. But I wanted to ask TK, and then maybe we can kick it to others. Why is it important that all the three types of medication are provided, even if maybe one is easier to deliver or store than the others?
So for one, right, I think the biggest reason is the fact that, right, each of us individually, right, our bodies process things differently, right? And so one medication that might work for me, like Suboxone, might be something that works great for me, and I have a lot of efficacy with that, but you might take it, right, and it might not have the same effect for you, right? Other people, right, sometimes have negative reactions and side effects to particular medications. So to have a wide array of options for people to make sure that their needs are getting met is important. And some people, right, some people don't like medications where they have to be injected with needles. Other people don't like, right, the sublingual films, right? Other people might not like, right, the waiting for things to dissolve, right? So having these multifaceted options, right, allows us to, again, like meet the needs of the individuals that we're serving. Because again, right, like we want to keep them alive, especially if it's a medication that's not effective for that particular person for a host of other reasons. It's important to have other options so that way they can still engage in the program itself.
Excellent, thank you. And maybe this next question, I know Chan or Regina, is a question, do you have a position on whether it's better to have facilities set up their own programs versus facilities linked to a community-based program, which, you know, might be the program that the person is, when they leave jail, would be going to in the community and might ease that transition? Is there kind of a thought around that?
Well, from my research, my position is whatever works for your state and whatever is going to work long term. So if the research or on the ground, review says that having a link is the best way to do it going forward, we're not going to take a position on that, because at the end of the day, we just want it to work successfully for your program. And that's one of the reasons why we have so many references to secondary sources that may help you look and review what in the long term works for this number of persons, this distance from the correctional setting. But we don't have a specific position on one versus the other, or specific preference.
I mean, I think the policy wise, it's the seamlessness of the transition that could be made by having the same provider in the jail as out, which is great. It could also be that, I think in upstate New York, they do this where they set the person up, they give the person a prescription, they set the person up specifically with the follow-up appointment right there and remind them about the follow-up appointment so that they don't miss it. But it's the seamlessness and making sure that you don't just say, wave goodbye when the person leaves.
And we got a question about addressing treatment deserts. And I think that's a really critical question, right? We know the settlement with Whatcom County, Washington, there is no methadone in that regional area. And so the settlement only focused on buprenorphine, right? So how should that be addressed where there's really not availability of these medications around? And should that be a reason not to require it?
Well, and as you know, Shelly, from what we did in the MAT Act was we gave sort of extensive options on that. One, telemedicine. And I know that's not a cure-all, but that is definitely an option that we put into the legislative framework. Linkages to care outside of the correctional setting. And if it's truly a desert, we offer an exemption, but it's an exemption based on extensive review by either the Department of Corrections or a behavioral health agency, with the understanding that there may truly be no access to certain medications. And we recognize that we can't, we tried to write this outside of an ivory tower and what really the reality of what's really going on in different correctional setting spaces. So while we try to make it as feasible as possible to provide access to all FDA approved MAT treatments, we do recognize that the reality is there may be a few that don't have that access, and we do provide exemptions. And even within that, we still encourage them to look for ways to get people who need treatment to other correctional settings.
Great. So I think we're about at the hour. I wanted to give everyone a chance to make some closing remarks, and maybe with a question that somebody asked in mind about, how do we balance working with corrections to provide access to treatment while also advocating for moving away from criminal justice and carceral approaches to addressing drug use. I think that's, like we talked about, this is a parallel track that we're working on. So maybe, half a minute final thoughts from TK, then Shan, and then we'll turn it back to Regina.
Okay, can you say the question one more time? Say it over.
Just your final thoughts and, what's kind of the most important takeaway.
So definitely, right, as always, it's always a pleasure to work with you, Shelly, and it's good to see you again, Regina, and meet you, Chan. I'm glad that I was able to be a part of this conversation because I think that these conversations are necessary. I think that the key takeaway is, right, when we're in these institutions, to treat people like people, right? And to treat them with care and compassion, right? And sometimes working on, like, how do we personally work on those biases and stigmas that we have, right? To work on providing the adequate care necessary to treat individuals. And hopefully the more that we have these conversations and talk about it, we can continue to address those barriers that we're left with, because there's always going to be barriers, right, that come up. But the more that we talk about it, right, and engage and work on solutions to overcome those barriers, the more that we can do. And then hopefully, right, we have a lot of success. And I'm really excited to see everything that you guys come up with and do moving forward. So I appreciate you guys.
I just want to say, first, I want to say thank you, Shelly and Regina, for your work on the MAT Act. Could not have been done without you. And to kind of piggyback on, to go back to your question, Shelly, about how do you merge sort of the two different tracks, I found that the people that were most passionate about helping us review this and talking about what needed to be in the legislation were people who were in the criminal justice system, who had realized and recognized that MAT was the way forward to getting people treatment and to getting them out of the correctional settings. And so I feel if you can get buy-in from the people who are running your correctional settings and from your state policymakers, they will be the most passionate about it. And it was somewhere on our 12th or 13th draft, and I think I'd sent it to send it out again. And I was reviewing it, and I realized a lot of the notes were from people who were criminal justice persons. And so I think it's really crucial to explain and to show and to illustrate that this is not some hippy dippy, love in where we're just like, let's give everyone treatment. This is literally a disease, and we are addressing it through legislation because we recognize that this is a problem. Thank you.
Great. Thank you, TK and Chan, so much for joining and for all that you do every day. Turn it back over to Regina for final comments. Thanks.
Thanks so much, Shelly and Chan and TK for participating. It's just great. And, one thing that, again, we try to infuse in all of our conversations is that, we talk to individuals who have, are really steeped in lived experience, research, policy, so that we can better inform policies going forward. And I was really, just touched by much of what was said on this panel, and it stresses the importance of moving forward with this legislation, as well as continuing to address substance use disorders, and again, meeting people where they're at. So one other piece that we're doing at Georgetown is we are starting a Master's of Addiction Policy and Practice. It will begin in July of 2021. We're accepting applications now. And we have on November 9th at noon, we will have a webinar on going over what the program will look like. It's from July until the end of June. So it's a one-year program, 30 credits. And again, the point of the program is to kind of move the ball forward even further on addiction policy, where we actually have addiction policy that is guided by science and evidence, and that when policymakers are considering addiction policy going forward, they think about what does the science say as opposed to starting with the stigma. So we're really excited. November 9th at noon, we'll send out information about that webcast to everyone on this call and share it with others. And if you're interested in finding out more about it, just contact us at O'Neill and we will get you the information. So with that, I want to wrap it up and thank you again, and we will see you soon.